A very good morning to all of you. I am very happy that you made it despite all these rains and monsoon. Mumbai is such a lovely place to be during this monsoon. I'll be talking about the impact of obesity on fertility in PCOS patients. Now, we all know obesity is a common, a very serious, a very costly, yet a very preventable disease. I will not be diagnosing and I will not be telling you how to diagnose obesity based on BMI. I think we can just go with the definition of excess storage of triglycerides in the adipocytes and excess adipocytes in the body. Now, let's not pass the buck and let's not place the blame on lack of willpower and laziness as the simple answer for obesity. It's a multifactorial problem. It should be viewed as such and tackled as such. Now, let's look at these unhealthy and very unhealthy and alarming statistics on obesity from across the world. We nearly have tripled in obesity since 1975. 13% of adults are already obese worldwide, and nearly 40% and maybe even more are overweight. And imagine what's going to happen to those overweight adolescents and overweight adults when they touch the later phases of life. Now, what is more concerning and what's more alarming is that 75% of Americans who are very well educated, who are affording, and they're actually doing zero physical activity in their leisure time. So that's something that's the most alarming in these statistics that I presented. Now, is Asian and Indian obesity different? Yes, it is. We would like to diagnose overweight in our population at a BMI starting from 23 to 24.9, and we would like to diagnose our obese at a BMI of more than 25 or equal to 25 compared to the Caucasian counterparts, because we have a different genetic makeup and we have different predilections. The million-dollar question to all of you, I ask myself and I ask all of you, where did all this PCOS come from? Is this the disease of the modern women? Is this the disease of our unhealthy sedentary screen and sitting times? Is this the disease of us sitting in long duration workshops and conferences? So what I'm trying to tell you is that between the talks, I want all of you to take a walk, just a generous walk. So I think this is a disease of modern times. Maybe we always had the genes, but we didn't have the push for the environmental trigger, and that just came with our lifestyle. Look at this statistics. So we have an alarming rise of PCOS. It was not a disease which was much discussed in the past, not because they did not have enough data, but probably they did not have enough of environmental push to cause PCOS. And I'm sure, and I think everybody will agree, there's a further worsening of the PCOS pandemic with the pandemic of COVID. Is there any shared genetics between PCOS and obesity? Yes, nearly 40 to 90% of PCOS patients are either obese at the beginning or they become obese later on in their life. If we look at obese individuals compared to lean ones, they have 2.77 odds ratio of becoming PCOS later on in life. So there are some mechanistic links, genetic links for the development of PCOS and obesity. And one of the most important ones is the FTO gene, which is implicated in the determination of fat mass in the body. So to sum it up, the expression of polycystic ovary syndrome is regulated at least in part by weight and BMI. Now let's look at how obesity wreaks havoc as far as fertility is concerned. The risk of infertility in obese women is at least 3 times higher compared to their lean counterparts. Their time to conceive, time to conception is much longer. The pregnancy rates with or without assisted conception are lower. Their requirements for oral ovulagens as well as gonadotropins are definitely higher, and they do have a higher miscarriage event rate. So this is just a slide to sum up the pathophysiology of how obesity causes infertility. Let's start with fat becoming an endocrine organ. Whenever there is fat deposition and whenever a woman is obese, so her fat compartment starts behaving as an endocrine organ. It starts secreting leptins, there is decreased ghrelin, there is increased inflammatory cytokines, hyperandrogenemia, and there is definite insulin resistance. So whenever there is insulin resistance, there is a consequent hyperinsulinemia, and we all know that insulin acts as a co-gonadotropin in the ovary. So what insulin does, it causes intra-ovarian hyperandrogenemia. It increases the androgen production in the ovaries, and that hyperandrogenemia, along with insulin resistance, becomes the driver of infertility in obesity. Now, there are decreased gonadotropin levels, decreased SHBGs, endometrial receptivity takes a beating definitely because of stromal desidualization and poor blood flow. There is early follicular atresia, there is intra-ovarian hyperandrogenic milieu which causes delayed maturation of the oocytes, and there is increased apoptosis. Now, if we look at these inflammatory cytokines, there are reactive oxygen species, and they all alter the steroidogenesis and the consequent ovulation in the ovary. There is cytoplasmic maturation delay, and there is impaired meiosis in the oocytes of obese. So when we do assisted reproduction, we tend to get smaller, less fertilizable oocytes. The live birth rates reduce with increasing BMI. And if we look at live birth rates in obese women, where BMI is exceeding 40, there's a 50% reduction in live birth rate. We're talking about halving of live birth rates in obese women. Let's look at these obese eggs. High levels of insulin, high levels of triglycerides, C-reactive protein, and lactate, which are all inflammatory cytokines. There is mitochondrial dysfunction, there is malaligned spindles, and there is disarrayed meiotic spindles. These all cause unfertilizable and poor quality oocytes. They definitely need higher doses of gonadotropins and a longer stimulation time. And despite that, we have a low site yield and a high cycle cancellation rate. Now let us look at the poor endometrium in these obese women. There is a definite delay of window of implantation, and this delay is directly proportional to increasing BMI and metabolic perturbations. There is an altered gene expression in obese patients, and that definitely contributes to higher miscarriage rates as well as lower implantation rates. So this is a confounding thing, and we, along with lower implantation rates, higher miscarriage rates, we have poor quality embryos because we have poor quality oocytes. So you can imagine that's the effect that they have on the lower birth rate. That's why we have a progressively decreasing lower birth weight in these women. Now again, looking at endometrium in obese PCOS, so they have a higher expression of androgenic receptors. So that's a picture that we used to see on our TV screens when the receptivity would be poor. Do any of you relate to that? Yeah. So there is a progesterone resistance in the endometrium because there is a decreased expression of pro-implantation genes. There's a decreased expression of integrins, hoxaten, IGF binding proteins, and this all leads to overall progesterone resistance. Now this was a study in which they saw the live birth rates in women surrogate mothers with BMIs exceeding 35 was 25% only compared to live birth rates in surrogate mothers where BMI was less than 35. So that's almost, again, halving of live birth rates. So this is a huge study of nearly 293,000 fresh IVF cycles taken from SART registry 2008 to 2010, and they had cohorts based on normal BMI, high BMI, and obese ones. And what they concluded was that success rates and odds ratio of all pregnancy outcomes, as well as reproductive parameters and ART outcomes, was negatively impacted by BMI, and everything was worsening with the increase in BMI. So this was yet another study to determine whether PCOS adversely affects IVF outcomes in obese compared to lean counterparts. I want you to focus on table 1 and table 3. Table 1 is where they compared lean PCOS with obese PCOS, and they saw that gonadotropin usage was obviously higher in obese PCOS and it reached statistical significance, while as the oocyte yield, despite having a longer stimulation and a high gonadotropin usage in obese ones, was much less compared to the lean ones, and again it reached statistical significance. Let's move to the table 3 at the bottom of the slide, where they compared obese non-PCOS with obese PCOS. And they saw that good grade embryos were higher in obese non-PCOS compared to obese PCOS. And total number of transferred embryos was also higher in obese PCOS. So to sum it up, lean PCOS behaves better than obese PCOS, and obese PCOS behaves worse than obese non-PCOS. So that means both obesity in the form of BMI and PCOS status, they negatively impact the reproductive parameters. They concluded that lean PCOS have better ART outcomes, but since this was a small study, it did not reach any statistical significance. Now, this was a study which we did on 412 patients undergoing IVF at Gynaec World. It's an unpublished study. And we had, just look at the percentage of women who are overweight and obese. There are only 25% normal BMI women who are actually undergoing IVF. So this is after having tried the lifestyle modifications to reduce BMI. So we have 75% overweight and obese patients, and look at their IVF parameters. Gonadotropin stimulation, definitely higher and obese and overweight. Despite that, oocyte yield is statistically significantly lower in overweight and obese. And we have an endometrial thickness which progressively decreases with increasing BMI, again reaching statistical significance. Yet another slide from the same study, look at the fertilization rates and live birth rates. We have a live birth rate touching 50% in normal BMI PCOS women, and we have a live birth rate of 25% in obese BMI PCOS women. So that again correlates very well with the worldwide statistics that with increasing BMI, there is a definite and a drastic decline in live birth rates. So I've just made a table in which I have tried to show you in a nutshell different studies that have evaluated the association between obesity and the outcome of assisted reproduction. Yeah, so this was a study which had very few number of patients, around 16, but nonetheless, oocyte yield, implantation rate, and live birth rates were compared between lean and obese PCOS patients. And definitely all these parameters were at least very, very drastically reduced in obese PCOS patients, reaching at least 50%. Another study of around 72 PCOS patients, they compared clinical pregnancy and live birth rates in women with BMI less than and more than 40. Look at the clinical pregnancy rate, 72% versus 32%. Live birth rate, 60 versus 32%. So that's a drastic decline one more time here. So another study with 55 PCOS patients, they compared implantation rates in different BMI categories, and they found the implantation rate was highest in BMI category of less than 18.5 and lowest in BMIs exceeding 30. Adam Bailey in 2014 reported on 79 PCOS patients a clinical pregnancy rate of 57% compared to 35% in BMIs exceeding 30. So to conclude, increasing BMI worsens all reproductive parameters in PCOS patients. So what's the way forward? Definitely lifestyle modification and weight loss is the first line treatment. It restores ovulation, it restores cyclicity, and bariatric surgery patients have been found to have good spontaneous pregnancy rates as well as better IVF outcomes. So we do have pharmacological treatments like orlistat and insulin sensitizers, and we do have lifestyle modifications and surgical treatment. Now, if we look at lifestyle, there are challenges. There are definite challenges which all of us are facing. Retention of subjects is very, very difficult in the long-term lifestyle modification. And what do we recommend? Do we recommend just caloric restriction? Do we recommend exercise? Do we recommend a combination of everything? And then again, we have orthopedic limitations because morbidly obese women,
Dr.
they
Sabahat,
usually,
you
yeah,
need to
I'm just
conclude,
finishing.
yeah.
So orthopedic limitations in morbidly obese women, they're not able to do everything. So to conclude, obesity is lethal. It kills, it leaves us with many comorbidities. It's a death by 1,000 cuts. It definitely wreaks havoc on fertility. And encouraging weight loss in obese infertile women is among the first line therapies. But whenever we are postponing pregnancy to achieve an optimum BMI, we must always balance it against the risks of age related fertility decline. Thank you very much. Have a lovely day.